On this edition of Insights on PBS Hawaii, we'll talk with some of the people on the front lines of healthcare reform in Hawaii. What is the state's plan for healthcare transformation? How does it align with the national law known as Obamacare? And how will it impact you? Now, live in our studio, our host, Dan Boylan.
Aloha and welcome to Insights on PBS Hawaii. I'm Dan Boylan. In 2010, President Obama signed into law the Patient Protection and Affordable Care Act, now better known as Obamacare. Despite opposition, the law was upheld by the United States Supreme Court earlier this year. It was a prominent issue in both the 2010 midterm elections and our recent presidential campaign. With Obama's re-election, this overhaul of our health insurance system appears to be secure. Hawaii Governor Neil Abercrombie has made its adoption a priority of his administration. Hawaii, of course, has long been a pioneer in healthcare coverage. The state's Prepaid Health Care Act helped the state achieve one of the highest rates of insurance coverage in the country. We were also one of the first states to begin carrying out the mandates of the Affordable Care Act. So what changes can we expect to see in the quality of medical services under the new National Health Care Program? Of all the topics we talk about around this table, and we talk about a lot of them, healthcare probably impacts us more than any other. It's literally an issue with life and death consequences. So we hope to hear your concerns tonight. What is or isn't working with your own health coverage? What do you want to know about the Affordable Care Act and the state's plans for health transformation? What changes do you hope they'll make? You can join our conversation by calling, emailing, or tweeting your questions and comments. The contact information you now see on your screen will be repeated throughout the program. Don't forget that Insights is also available live on your computer screen at pbshawaii.org. And as always, the video will also be posted online after tonight's program. Now to our guests. Beth Giesting is Governor Abercrombie's coordinator for healthcare transformation. That's a very big word, transformation, overseeing the state's compliance with the Affordable Care Act. Before joining the governor's staff last year, Beth was chief executive of the Hawaii Primary Care Association, working to improve access to care for poor and uninsured residents. Prior to that, Beth was executive director of the Kali'ipalama Health Center. Ginny Pressler is Executive Vice President and Chief Strategic Officer for Hawaii Pacific Health, the nonprofit parent that includes Straub, Kapiolani, and Palimomi hospitals. Ginny is a physician with a specialty in surgery. She has previously served as Deputy Director of the State Department of Health and Vice President of the Queens Health Systems. She co-chairs the Hawaii Healthcare Project with Beth. Danieley is a vice president with Kaiser Permanente, overseeing health plan service and administration, which is the insurance side of Kaiser. She is also president of a Kaiser subsidiary, Rainbow Dialysis. Joan is on the board of the Hawaii Health Connector, which we'll talk more about in a few minutes, the Hawaii Healthcare Project, and the Hawaii Association of Health Plans. She's been managing health insurance plans for 20 years. And State Senator Josh Green will continue as chair of the Health Committee for the upcoming session. Dr. Green represents Kona and Ka'u on the Big Island and works there as an emergency room physician. He's also medical director of the Hawaii Independent Physicians Association. Josh first came to Hawaii Island as a member of the National Health Corps to treat patients in underserved rural areas. We appreciate all of your coming tonight, and this is a complicated topic. I realize it every time we come back to it, and if I've messed anything up so far, please feel free to make it clear to me. But how are we going to mesh these two things, namely our prepaid healthcare system that we've had in Hawaii for a long time and this new Affordable Care Act? Beth, how are we going to make it work?
Well, in fact, it is not looking like it's going to be nearly as complicated as we feared. Hawaii, because of our Prepaid Healthcare Act, is way ahead of most other states in terms of defining a very comprehensive set of benefits, trying to make sure that virtually everybody has health insurance. So we're doing many of the things that the Affordable Care Act is trying to do in a different way. The federal government is, I believe, going to be very supportive of ways that we can take advantage of adding to through the Affordable Care Act, but keeping the nucleus of what we've got going. So I am very optimistic that we will be able to keep both.
But our healthcare position has gone down, hasn't it, in terms of the where we stand in relation to some of the other states? We used to be number one or number two, but we're not that anymore.
Well, we're pretty close to the top. We may be down as far as 3 or 4, but we're among the leaders. Massachusetts is number 1, and the second and third and fourth are clustered right there. We don't have very many uninsured people in the state.
Let's have some definition things here, because I certainly don't understand them all. I mean, we know Obamacare and the vaguest in sort of partisans ways of looking at it. But what do you mean by healthcare transformation? What's the Hawaii Healthcare Project? I know we talked about it 3 or 4 years ago, but what is it?
Well, you know, Dan, I think you hit the key word in your introduction when you said quality. And the future of healthcare, the thing that's most exciting to me is that it's all about quality, and the other big piece that it's about is patient engagement. Those are big changes in the focus in healthcare.
Which will be helped by the Affordable Care Act?
The Affordable Care Act enables many of the things that we've been working on for many years here in the state, and so this is really going to help us kickstart and move things along. We're already leaders in the nation on focusing on quality and things like what we call the patient-centered medical home. People don't know what that means, but it has to do with not just a physician taking care of you, but having a whole team taking care of you. So you've not got just a physician, you've got a physician assistant, you've got a nutritionist, you've got an outreach worker, and you're getting patients engaged in their health care, active participants as part of the team taking care of themselves.
Now, I know everybody advertises that. Your outfit advertises that. Certainly Kaiser advertises that. I think that you've been trying to get that that kind of team approach established everywhere. But you know, I still remember, you know, Norman Rockwell covers of the single doctor looking at thumping the kid's chest or whatever. That's kind of gone, you know. And I go to see my doctor at Kaiser. She's sitting there, you know, saying, "How you doing, Dan? How you feeling?" She's looking at a computer screen, talking to somebody. Isn't that? I mentioned that to somebody who is in HMSA, and they said same thing. Is that team-centered?
You know, it is about the patient and about providing quality care to the patient. And healthcare reform is really encouraging everyone in the nation to look toward integrated care, which is what we have at Kaiser. And that is really one of the main focus areas of healthcare reform, and the patient-centered medical home, which all of our clinics are certified patient-centered medical homes. That is a place where you can go and that physician knows you, and yes, they're looking at your electronic medical record, but that electronic medical record is key to providing the quality care that our community needs.
Could just be the way I look, Joan. She doesn't want you don't see any problem in the two systems meshing. You think it's going to work?
I don't see any problem in the meshing. Really, Obamacare gives us a structure, and when you say transformation, it transforms people's approach. So now there's a structure to do these things like patient-centered medical home, outcomes-based medicine, healthcare savings through the Medicare plan, and we were already so far ahead of almost every other state in Hawaii that we were able to start focusing early on the things that Ginny and Joan and Beth are talking about to get these outcomes out in front. Now, I'd like to comment on your Norman Rockwell comment, though, because I'm a trained family practitioner, and the image of the solo guy with the stethoscope, I mean, it's still, the doctors are still like that. But healthcare is so much more complex than it was 40 years ago. When now you have very fancy tests, you have CAT scans and MRI scans, you have very advanced surgical possibilities, and all these subspecialties that grew out in the last 30 years, that it can't be the exact same experience that people used to have. But you can still have a terrific primary care provider at the center of your team working with this collaborative. And I think that that's what people are trying to express. But it's a matter of time has moved forward, and now with all these other options, other medications and whatnot, I think it's just kind of a natural change.
And Dan, I would say actually by using technology, we're able to actually go back to the Norman Rockwell type of care. But then you have a lot more information that we didn't have back in Norman Rockwell's time. And now the patients can be active participants in it because they have access to the information that they need in order to be active participants in their care.
Yeah, but still an awful lot of medicine is chest thumping, right? And trying, well, coughing, I'm not sure. All those things you ask a person to do. Still a lot of medicine is still that, and yet didn't I read somewhere that 35% of our docs in the United States are primary care physicians and 65% are specialists, as opposed to Europe where it's about the opposite of that, and they tend to do better in terms of at least people staying healthy than we do.
That's a very important point you make because we are upside down. Our pyramid should shift, and the things that you're seeing now will shift us back towards the primary care focus. We should be 2/3 primary care and preventive medicine and 1/3 specialty. And the things that have been going on here in our state are moving us that direction. Kaiser's influence has been profound in that area. Also, HMSA has really made a concerted effort to, through the medical home, through the patient-centered medical home, Hilton Raythor, Mike Gold would tell you this, that they're putting more resources into primary care practices to make it more possible to get the young medical students to go into primary care. It's also the reason that many of us, in fact all of us, have been fighting for things like this loan repayment bill, which we finally passed last year. Pay back medical school loans for people who go into primary care. It's easier to get them there with their stethoscope, checking people's blood pressure, making sure they get immunized, the real core basics of healthcare, so that we can have a better system without the real high expense end-stage disease that really ruins the healthcare system.
Our incentives over the last few decades have been discouraging primary care. There's all been towards specialty care because that's where the reimbursement has been. Now we're seeing that it's shifting back the other way. And what we're doing is providing the tools and the resources to the primary care physicians so that they can be much more effective by using technology so that they can continue to do the high-touch piece along with the technology.
And healthcare reform is actually giving us funding so that we can do more of the innovation around patient-centered medical homes and around putting the patient at the center of care with their primary care physician.
I know that this guy over here is always argued that prevention is what it's all about, that we've got some of our biggest eaters up of health are diabetes, and which deals with obesity, smoking, cancers, and so forth. But what's the Department of Health doing and other agencies to see that health and wellness programs are supported throughout the state and to stop, to try to stop some of these chronic
Well,
things?
the Department of Health is absolutely crucial as a partner in transforming our healthcare system because, as you point out, so many of the diseases are chronic diseases and they're really based on behavior. So we need to rely on and help support and augment what our Department of Health is doing as well. And I think that as far as the healthcare delivery system is concerned, that's where being patient-centered, adding coordination and nutrition and all of the preventive services that need to be part of our system and have never been part of it before because nobody ever paid for it before. So we do need to take all of those public health best practices and add them to the extent possible to our delivery system.
The exciting thing is Obamacare is about quality of care for the individual patient experience, reducing the cost, being more cost efficient, but also looking at population health. So now you're beginning to see it's not just the role of the Department of Health to take care of population health and make sure that we're doing the right things, but it's part of our Kaiser and for Hawaii Pacific Health, HMSA is encouraging so that the incentives are there for everyone to be working on trying to improve the health of the whole population, trying to reduce obesity and hypertension and diabetes and things like that.
And the electronic health records, the ability to move those records around the healthcare system as needed and to aggregate the information, analyze it, and use it is really crucial in improving population health and as well as being the foundation for pretty much everything else that we want to do.
Brian from Waipahu wants to know, can we penalize people with unhealthy habits by making them pay more, like car insurance penalizes tickets and accidents?
Yes, we can now. The Affordable Care Act actually allows us to increase premiums as much as 50% now for people who smoke. That didn't used to be allowed.
That's right.
You can do that? You
Yes.
can do that at Kaiser? Every insurance can do this?
It is now allowed under healthcare reform. There have been some companies on the mainland who had tried doing this, but now there's actually approval in healthcare reform that you can increase it as much as 50% for employees who smoke.
If they're not doing something to try to stop smoking.
Yes.
Right.
And then even better, you can give them a carrot for joining a cessation program, which would encourage them to then stop smoking and get that premium back down.
And a lot of these services are going to be covered now. So people complained about the, and I did too, about the 2,000-page bill that came out of Congress. Right. And there is a lot of dysfunction in Congress, obviously, but deep in those bills were discussions about these things, about can we put more incentives to get people to be proactive about their health? Can we put together certain committee work that can better do things as small as school gardens and local agriculture, unbelievable things that you might not think are central to health care, but really are, because when they're about diet, they prevent diabetes, and diabetes is 10% of the healthcare spend in America. That's $300 billion is spent on diabetes-related illness, most of which, in a perfect society, we could prevent. So the grand scheme of things is to get health technology into place so we really know what's driving cost and driving poor health in America, what's the best practice for physicians, for the person with the stethoscope around his or her neck, and then really go after the things that work. And I think that that's the idea, and to get everyone also covered. So we don't just have a sample of America, we have all of America, and we're going forward as a country rather than leaving people behind.
Where are we with the Affordable Care Act and our own system that we've got? What percentage do you feel will be covered once the Affordable Care Act is all totally in place? Will we have 100% coverage?
No.
Here in Hawaii, I think that we will still have a couple of percent uninsured. The way the Affordable Care Act works is we expand public insurance, Medicaid, up to 133% of poverty. So everybody whose income qualifies them for that, they can get covered by public insurance. We will have the insurance exchange, the connector, which will be a market where people can get insurance at a subsidized cost so that they can afford it. There is an obligation, there are penalties if you don't get insurance, but there undoubtedly will still be people who fall through the cracks.
Yeah, explain that exchange
Okay.
a little more carefully.
So the insurance exchange is intended to be an insurance marketplace, and in this day it is a web-based marketplace, although they have real live people who will also help people get through the process. You put your information into the database. It determines whether you're eligible for public insurance, whether you're eligible for a subsidized program, or whether you're eligible to buy your insurance but get no subsidy. So if you're eligible to buy insurance either subsidized or not subsidized, you have these various insurance products available to you. They're supposed to be in user-friendly information, not insurance speak, so that people will be able to understand what the various differences are between them and which one will work best for them. They can purchase the insurance online, and they will, and if they qualify, they get federal tax subsidies to help them pay for it.
And I think it's important for people to know that beginning in 2014, there is an individual mandate, and people are going to be required to get coverage. And one place to get it, and the only place you can get the premium subsidy, is to purchase through the insurance exchange.
Now, who's going to be, I know, I assume HMSA will be in there, and Aloha Care, and you folks will be in there, Kaiser, and everybody, and other people will come into the market, I assume, right? Now, how do we know that the plans that they offer are going to be as good as, we've long been accustomed to? I mean, 90% are covered by two, right? You guys and HMSA. And HMSA was asked to be here tonight, but I think their Christmas party's on. For some reason, they couldn't make it.
Today is actually Bob Hyam's retirement party.
And,
yes.
Oh, well, that explains it. That explains it. But there'll be others coming into the market.
Mm-hmm. Yes, I heard from former Commissioner J.P. Schmidt that there is someone that's conceiving or considering coming to the market now. And having additional options will make it better for consumers, there's no question. But you did ask an important question, which is how do we know it will be a good enough plan? And there's a standard that's already been set and chosen by the governor. So it will be a plan that's, I guess, going to be very similar to HMSA's PPO plan, I think, is the threshold, which means you'll get coverage for essentially all of your health care needs. Because the idea for health care reform is to get everyone covered, but not provide insurance that isn't helpful. So this threshold will be set, and if it works through the exchange, which I do believe it will work, we'll be able to get people an easy access to the most affordable plan for their family.
Now these will be available to people online. You'll just go look at them. Now, what's the connector? Is that where these this staff of this group decides who's allowed in the market, or what are they doing? What are
it's highly regulated.
Yeah, it's highly regulated.
Yes.
It's still, the insurance commissioner still has to approve which ones are qualified to participate, and they have to meet the essential health benefits, as we said. And the connector is the Health Insurance Exchange for Hawaii.
And it's a nonprofit organization that works with state agencies.
Well, let's get a few more agency names in here, can't we? I mean, I'm halfway serious. I'm only partially joking here. Only partially joking. It seems to me that, as with Medicare and Medicaid and all of these other things that have to do with health care, that they're very complicated. And I'm an impatient person. I just don't pay any attention. But it seems to me that for a lot of people, they probably don't want to deal with all of this. Is this going to be simple? Is this going to be easy for people to deal with?
The objective with the connector, with the Health Insurance Exchange, is to make it easier for individuals. You go online, you put in what your demographics are, and then you get put into the right options. So you can, just like Travelocity or something, you can choose which are the available options for you, and pick the right plan.
And pay for it online.
That's right. And there will be people who can help you. There will be navigators and assisters that you can call, and they will help walk you through the process and help you do the shopping. And it's really set up to be a shopping experience.
Now, I know a doc in Hawaii who always complains that we don't have enough doctors and that we're way below the number of doctors that we should have, and that we're going to lose a lot of doctors very, very soon because the older guys don't want to deal with all of this transformation, and they're just going to retire and go out of the system. I know a doctor who always is complaining about that. How are we going to see to it that we get more doctors when they're, increasingly we're going to be looking for one kind of doctor, the primary care doctor? How are we going to attract them?
Well, just let me give you some perspective on the numbers. So we have about 100 to 120,000 uninsured in the state. And you asked, will everybody be insured? No, not everyone, but we'll get to 96, 97% insured in the state. And that means we have to basically include another 100,000 people in the care in Hawaii. An average primary care doc takes care of 2,000 to 3,000 people. So we have to come up with 30, 40, 50 additional primary care physicians in the somewhat short term. And JAPSOM can only train so many. They have 68 students per year, then they have to go to their residency. So what we are doing is a couple things. We have to repay primary care physicians' loans or give them incentives to come to Hawaii. We're on that. That is actively happening right now because of last year's legislation and also donations from the private sector. Number two, we do have to transform our system, and that word's been used a couple times, which is to say that you're going to see in the medical home term, we're going to see nurse practitioners and physician's assistants play a larger role in some primary care, unless society decides they want only physicians providing that level of care, in which case there has to be a national movement, and this is provided for in the Affordable Care Act, in Obamacare, to spend a lot more money on grants and training. But it's a challenge. There's a finite number of medical schools. There's 170 medical schools in the country. If you look at nationwide, we need 12 to 15,000 more primary care physicians tomorrow. And that number is much bigger going forward as the population ages. So we have to have a national movement to train physicians either more quickly or more robustly. And it's going to cost money. But there will be partnerships with nurse practitioners and other supportive team members, and I think that's what a lot of people will see their care delivered. You'll see your physician for the big moments, and sometimes you'll see a lot of additional very well-trained people helping you with some of the more basic parts of healthcare.
Yeah, we have to get smarter about how we provide the care. And this is a national problem, as Senator Green said. It's not just
the nurse practitioner, for example. I've known some pretty smart nurses in my time.
Yeah, they're great.
That I'd trust them with almost anything. I mean,
be part of the care team.
will the Health Care Act put the financial viability of the present health care insurers in Hawaii at risk in any way?
I don't see that happening. I think in the long run, the Affordable Care Act is economically a sound move for the nation. And in aggregate, the nation is a lot worse off than Hawaii because we have a lot more uninsured people. But here in Hawaii, I think that we have an opportunity through the Affordable Care Act to transform, again that word, our healthcare system and our costs to be more sustainable. And what we are really trying to do is integrate our system so that it is going to be more functional, and the insurers and the providers and the patients are all going to be working more closely together for the right outcomes. So I see that there is going to be a big change coming our way, but it's going to be for the best.
It is telling that despite our country's deeply ingrained wariness of big government, the march toward national health care continues to move forward. How will private insurers adjust to this changing landscape? Richard wants to know, are they adjusting?
Well, I would have to say that contrary to many people's belief, with Medicare, Medicaid, public employee workers, and retirees, between the federal and state government is paying for by far more than half of the cost of health care. And much of that is being contracted out to private insurers. So there is already this dynamic going on. So this is not disadvantaging commercial insurers.
Anonymous, this guy's watching every one of our programs. Anonymous here. Doctors say that insurance companies add to their costs by requiring prior authorizations and approval. Doctors' admin costs have tripled. How will Obamacare help with those costs? Does it?
It doesn't help enough yet. This is one of my personal pet peeves with the Affordable Care Act right now. And that's, like, for instance, last night I spoke to the Family Practice Association, and that was their #1 concern, that they have still a lot of barriers to actually just deliver basic primary care to people because of all the paperwork and complications. That has to be simplified. In fact, some of the focus at the legislature this year and next, I think, is going to be about practice simplification. In a better healthcare system, doctors can do a lot more, nurse practitioners can do a lot more, and I think we're going to see, because of the Affordable Care Act, some streamlining, but that's going to be incumbent on each state to take up those issues, because there's only so many details that were actually put out by the Affordable Care Act. Now we have to dig into our own healthcare environment here in Hawaii and ask for instance, HMSA and other plans to have a single prior auth, irrespective of the plan, whether it's their private plan or their Quest plan, because docs really, at the end of the day, it's not about money for them. It's about seeing their patients and getting on with their day. And I had one doc tell me that he's now spending 3 to 4 hours a day going through the paperwork of medicine. He could be seeing 20 additional patients a day, which is really what we wanted him to be doing.
Yeah, that's actually one of the objectives of the Affordable Care Act, and a commitment that was made by the industry to all work together to try to streamline administrative overhead and all those complications, and to reduce administrative costs. And here in Hawaii, we have the health plans, through the health transformation, through the Hawaii Healthcare Project that Beth and I are on, to voluntarily say, let's see what we can do to streamline and standardize and simplify administrative hassle so that it's easier for the physicians.
That's exactly right. And I think that the focus and that trend toward pushing people more toward integrated care, then the referrals don't become what it's all about. It's about the integrated care with the physician as the leader and that physician-patient relationship. So I think that the move toward integrated care that's really encouraged by the Affordable Care Act is going to move us in that direction. But this is our first step in what's going to be a long evolution.
Yeah, I'm optimistic that as discouraged as some physicians are with all the changes going on right now, that their climate, their situation for being able to provide good care for patients is going to be much better in the future than it is now.
Well, I read an article in what was The Economist saying that Hawaii was a desert, not Hawaii, the United States was a desert in terms of health, any lessons that we have to give anybody else on healthcare. But that Kaiser was an exception to that, the Kaiser Permanente nationally. But in their argument, they kept talking about this integration, right? But I'm not quite sure I really understand exactly what that means. I mean, you still get referred to somebody. The guy who is the specialist gets paid a lot more than that primary care guy is, so the emphasis is on that. I mean, that's where the pay is going, and no matter where you are. The only thing different that you guys have is you salary people, right? So there's not the fee-for-service stuff.
The payment is changing.
It is, and it's really about aligning the incentives. Within fee-for-service, the incentives are for more care. You get paid the more and more you provide. Within an integrated system, everyone's incentives are aligned, and that is the beauty of the Kaiser model and why it's so unique, is that the physician incentives, the health plan incentives, the financing piece, the hospital, everyone's incentives are aligned so that the focus becomes what does this patient need in order to have quality care.
So Kaiser is ahead of the pack in having this concept that works, but it certainly is an idea, a way of delivering care that can be embraced and carried out elsewhere. And I think Ginny's hospital is.
Yes, at Hawaii Pacific Health, I think, the accountable care organizations that you hear about, we're creating a clinically integrated organization so that we can create the environment to make it easier for our physicians to provide quality care. And we are negotiating with our payers, our insurance companies, to pay us based upon quality outcomes. So the end point is the outcome, how well we've taken care of our patients, how well we've managed their blood pressure and their diabetes and their weight and stop their smoking and those kinds of things. We're accountable for that, and that's how we'll get compensated. So all of the incentives are to work together collaboratively, use the specialists that you need appropriately, and all of the other support that you need on the team to work with patients to have them have better health outcomes.
At the new cafeteria out at UH West Oahu, I complained because they have good food, but they don't have any trays. And I said to the guy who managed the thing, John, I said, John, I'm a strong, big eater, and I'm an old man, I'm going to drop stuff. And he says, well, I said, so where are the trays? I thought, run out of money. I didn't have enough money for trays. He says, no, it's our plan. He says, you got to carry your entree, you got to carry your drink, and you pay your money, and you're not going to take as much. You're not going to eat as much. And we're fighting obesity. Mm-hmm. And at first I thought, oh, now I'm beginning to change. You want to take the sugar out of pop, right? Are you going to still push that bill?
I think I probably will. And I'll tell you what, again, let's put it in perspective with the Affordable Care Act. The idea is to look at population health rather, across the country. And so when we say again that diabetes consumes 10% of the healthcare spend, and that in Hawaii we had an increase by 117%, we saw that reported by the Advertiser the other day in diabetes over the last decade. We have to do something about these problems, and so there has to be a comprehensive approach. Ginny and I are sitting on the obesity task force right now together, and whether it's a tax on soda or whether it's improved exercise and a much better health approach with physicians coordinating their care, we'll see what comes out of the legislative session. But these things have to be addressed, and because the Affordable Care Act is putting the emphasis on primary prevention and simplifying, hopefully, the practice of medicine, we can actually pick these problems, whether it's childhood obesity, which I definitely believe is one of the main problems, and I think treatment of drug and alcohol abuse, actual treatment of it, which drives costs very badly, and it's devastating to families. These are going to be the new areas of focus in healthcare, rather than waiting for people to be ready for terrible heart condition needs. bypass, whether they're going to have surgeries because they need amputations from diabetes. Instead, our teams, which you've been hearing very well described, will be focusing in advance on asking those questions in the encounter with the primary care physician, so we find out if someone's got alcoholism, so we find out if they have very poor nutrition and that's why their child's already obese at age 8. These are the fundamental changes that when they happen in the healthcare system, we will see costs decrease and we'll see a lot better healthcare. That's my hope. It's not so much about just banging Pepsi and Coke over the head, although we do that periodically. It's really about saying to the healthcare providers, this should be your focus instead of paperwork, instead of specialty surgeries.
It make me feel guilty about doing so many things that I like to do and eat and drink. I believe I heard Joan say Kaiser can charge 50% more for an employee who smokes. As an employer who provides only Kaiser, I've always been charged one rate for all employees. Does this mean my rates will go up for every employee because I have one who smokes? What are the ramifications if I don't hire someone because they smoke?
No, Kaiser is not utilizing that at all. That is just something that is allowed under healthcare reform, but it is not something that we are utilizing.
Jackie and Kaimaki, I'm unemployed but don't meet the poverty level that the state requires, so I have no health insurance and can't afford any. How will the Affordable Care Act help me?
The way the Affordable Care Act will help is that you go online, you put in your demographic information, including your income, how many people are dependent on that. It will tell you whether you might qualify for public coverage, which even if not qualified now, might change in 2014 because the eligibility level goes up. But if not qualified for that, you can see if you are eligible for a tax incentive that will help pay for your premiums.
I can give some specifics on that if I might too. Beth's absolutely right. So the idea is that 80% of those who go through the connector will receive a subsidy in one way or another to get them insured. Otherwise, there will be penalties, and those penalties kick in after 2014 hits. At first, they're very small. There are still unanswered questions. I want to see it like everybody else. Are the penalties too high? Are they going to be used properly for that 3 or 4% of people who still refuse to get insured? Will we invest that money in our safety net, in our community health centers, in our patient-centered medical homes that Hawai'i IPA or Hawaii Pacific Health are founding? I mean, are we going to actually put that directly into care, which is what I'd like to see. So I want to see those dollars go to providers that are doing a good job, but that is the challenge. So that individual, though, if she makes somewhere at, say, 200% of the federal poverty level, and we could get those numbers for you, she would get a very significant discount on the insurance. And the idea is, though she'd be buying insurance, and that can be hard, then she doesn't have to worry about possible bankruptcy if, God forbid, she ends up in the ER.
Let's be sure we make this clear. You have deadlines. We're not close to full I can't say that word. Implementation. Thank you. Of Obamacare. So what are the deadlines you face?
So by October 2013, the website for shopping for insurance will be up and functional. You can start shopping after that date, but your insurance won't kick in until January 1st, 2014. But it has to be functional by that time, and at that point, we'll have more information about exactly how much that's going to cost and what the subsidies are going to be at what poverty levels.
Someone doesn't believe you. Ron from Honolulu says, who will pay for all this great stuff they're talking about? Doctors? Us? Who's going to pay for it?
So the federal government is paying for a lot of it. For instance, the expansion of Medicaid and the subsidies that are federally supported. So, for instance, increasing the up to 133% federal poverty will be that extra amount is going to be covered by the federal government, as I recall, right, Beth?
Right. And I guess what I would say is that we're all paying for our healthcare system now, and at least a third of the costs that go into it are wasted. And so we have got to make some serious changes in the way we deliver care, in the way we pay for care, and we need to make sure that everybody has coverage, because that really is a drain on our system too. We cannot make all of these important transformations unless we get everybody in the pool.
How can small business owners who are barely hanging on afford health insurance when they can't afford their own insurance? Susan Molokai wants to know.
Well, you know, the rate of increase in cost, you know, I can certainly relate to the small employer. My whole family are entrepreneurs, and so, you know, it's a problem for them. So I don't want to say that it's a minor issue, but the rate of increase in the premiums is starting to slow down. And all of the changes that we're talking about tonight, there's a lot of waste in the system still. There's opportunities to provide care more efficiently so that over the next decade, that cost trend should improve so that it's not becoming as much of a burden as it has been over the last.
Is it technology that's taking over that will make it possible to have these savings?
Technology is a part of it. There's things like, for instance, screening, integrating mental health into our everyday health care. Screening a patient every time they come in for depression. That's a major issue that boosts up our costs of health care. And then all of the waste that goes into, you know, sometimes duplication of tests or too much emphasis on the latest technology, where sometimes it's beneficial and reduces costs, but other times it actually increases the cost without necessarily improving care. So we need to be smart about how we're using that technology.
I'm sorry, Joan.
But the goal is, if you can get everyone insured, and if you can get the focus on prevention and focus on quality, then that should help you drive down and mitigate those increasing costs of health care so that we can make our entire healthcare system more sustainable in the long run.
Barbara from Honolulu wants to know, who will be doing the tracking to see if people have health insurance, and what will the penalty be? Do we know what the penalty will be? We don't know that yet.
We do, actually.
We do.
Yeah, the penalty is $95 per adult in 2014, or up to 1%, which is of their income, which is greater, whichever is greater. In 2015, it jumps to $315 per adult, or 2% of one's income. Now, I think that's going to be renegotiated and reviewed at the federal level, and it is going to be the IRS that's looking at this when people file their taxes. But let me again reiterate a couple points that are very important. Right now, if you're paying for insurance, or your business has been paying, or your family's been paying for insurance, and a large percentage of Americans, 15 or 20% in some states, aren't paying for it, when they go to the emergency department or when they get sick and go to the hospital loses money, and they pass it on, and it ends up being higher rates for everyone who is buying insurance. So already Americans are paying for the entire system, and it's been inefficient. The idea is to have everybody pay less if you're poorer, the same as if you were before if you have a job and your family's doing okay, so that we don't have these pitfalls in the system. Because in some ways it's been very unfair to those who have been playing by the rules and insuring individuals. Plus, and I can say this as an ER physician, when you go to the emergency department, it's far too expensive. You pay for inefficient services where there's excessive testing. That's the nature of the emergency department. People are practicing defensive medicine, what have you. If they just go right down the street to a community health center or a private physician, it's 80, 90% less expensive. And those are also personal decisions and personal responsibilities people have to take. If we get people actually insured, going to the right places through health literacy, the system can be much, much more efficient and much more fair to all of those viewers who are watching tonight who for years have been paying their premiums and often not even using the healthcare system. Sure,
yeah. And a lot of the health decisions we make in a home where we have an older person we're on the phone to Kaiser, saying to the health nurse, is this something that we need to come in for? And
the advice nurse.
The advice nurse, right. I don't make those calls. On a scale from 1 to 10, this person's filled out too many polls, with 1 being no change and 10 being revolutionary change. How big a change is Obamacare with regards to the way health care is administered in Hawaii and the rest of the country? Sarah wants to know that. Hey, come on, dude. Give me 1 to 10.
You guys start.
You know, I think initially patients are not going to notice too much of a difference, but pretty soon that's going to be ratcheting up, because we really want to emphasize patient-centered care, involving you as a patient in your care decisions, in making this whole system easier for you to use, making sure that all of your care is coordinated and it's not going to be a fragmented mess that you have to put together.
1 to 10, Beth.
Okay, you have to quantify it. Okay, so over, I don't know, 5 years, 10. It's going to be a big
Oh,
change.
really? That much? Revolutionary.
In the next year or two, 2 or 3%. 10 years from now, 10. I think healthcare is going to look totally different 10 years from now, and for the better, because it'll all be focused on quality and better preventative care.
And you'd have a lower number because you don't think Kaiser has as far to go.
You know, we are the leader, and everywhere I go, people come up to me and say, well, isn't healthcare reform trying to get people to be more like Kaiser? So I do think that we are leading the pack in the future of healthcare, and I think that it's not going to be as big of a change in the Kaiser world.
Well, imagine this, if you didn't have to go to your physician's office to get care. We have technology that can allow those kinds of things now. So I think that certainly Kaiser has been the model of integrated delivery system, but there's opportunities that we haven't even thought about yet because we've been entrenched in this old payment system. Now we're changing the way we pay for care, and there's all kinds. People are very inventive, as you know, when they have a little bit of opportunity to take money and spend it differently. We're going to find all new ways of providing accessible quality care to people that's going to be much more cost effective.
That's what used to confront people and say, on the mainland, just say, just do it the way we do it in Hawaii. Just do it the way we do it in Hawaii.
Yeah, it's a
1 to 10.
It's a 3 now. You won't notice much change. Your physicians will notice a little more change, but patients will not notice a lot of change up front. But it is true that as the generation turns over, everyone will come into, as the physicians and nurse practitioners and plans, will be looking at outcomes-based medicine, and so the system will be completely different once that whole generational change takes place. And I don't know if that's 10 or 15 years, but we will see a different healthcare system for the next generation.
Nani in Lehui wants to know, will Obamacare increase access, support, and funding for dental health care?
Yes.
It does for children.
For children.
Because the mandatory benefits that need to be provided by every health plan includes dental services for children. And I think that many of us are disappointed that it doesn't address dental benefits for adults, because for far too long we've been ignoring dental health and that need as a primary medical service.
There is an additional provision, though, and I know Beth and I've talked about this some, that $11 billion is being spent for the community health centers going forward, and that the community health centers have taken the lead in some areas to add dental services, especially for those who are either uninsured or underinsured. And that represents 1 out of every 17 people in the country gets their care at a community health center. So those families may have additional access. And it's important. Every weekend I see somebody with very terrible health problems from their mouth, from severe dental caries or abscesses, and it's often the community health center system that I send them to.
I think that's one of the changes we'll see over the next decade. We've had dental care has been sort of fragmented out, mental health care has been fragmented out, and I think we'll see it's all more integrated into recognizing it's all part of good care.
Dr. Johnson, a recently retired primary care physician from Kaneohe, says that I find my colleagues and I have had to retire because we know that one malpractice case can take away not only our malpractice insurance, but also our house, retirement plan, savings, and so forth. What is the state doing about malpractice insurance reform to protect doctors? Is anything being done?
I think we need to ask our senator here.
Yeah,
This is docs versus lawyers, right?
Yeah, I'm one doc, and there's 25 or so lawyers at the legislature, so that is a tricky
Good
thing.
luck.
They're good people, but we probably don't see eye to eye totally on this issue. What I think we do is need Good Samaritan protection for those who provide care in underserved communities at the very least, which is to say, if I'm that gentleman who was working in an area where he had no backup with a hand specialist or an endocrinologist or what have you, there should be some provisions made for people who are making a Good Samaritan approach, in this case as a physician, to deliver care that no one else would. That we couldn't get those specialists there for whatever reason, economics usually, to take care of that patient population. I think there is room for some compromise there. I have submitted the medical malpractice bill 3 or 4 times, and every once in a while it moves a little bit, but Hawaii does not look likely to be the state that will pass tort reform unless really the physicians all speak up and we can come to some agreement that there is a need to increase the capacity for care. We haven't had a lot of malpractice cases, but I think Dr. Johnson makes a good point. One case can turn a doctor to retirement.
How will this affect employer insurance? Will the employees have to go into the marketplace to choose their insurance?
No.
No.
Here in Hawaii, it remains the same. We expect to still have the employer mandate, and so if you're employed and your employer provides the coverage, that will continue.
Oh, this is for you. You take that home with you. Kaiser has had an integrated care model for many years. Why are their rates not significantly lower than HMSA?
You know, rates come from many aspects, and what we find is that we have to constantly be working on ways to mitigate the increases in rates, and we have to keep focusing on the electronic medical record and on quality and keep all of the incentives properly aligned, and then over time keep those rates mitigated.
How do you guys decide on that? I mean, you're on that side of the business, right? So you're sitting over there figuring out what you guys are going to charge, right?
You know, we're non-profit, and we really look at the experience that we have within the members that are in a particular group, and that's how the rating occurs, and that's where the premium's derived.
We have to talk, you know. How do you see Obamacare affecting medical research, not only in Hawaii but across the U.S.? Beth, I think you said in one thing that you sent us that research money, particularly for preventive, it looks like there's not much there.
Well, I think that some of the things that went into the original bill didn't get funded or have been delayed. Nonetheless, I think that there are going to be much greater opportunities for research, developing a body of evidence-based care, because we are moving everybody toward health information technology, using electronic health records, aggregating data, and when you put all of this data together, then you can see the patterns and see how things work. So it's going to be very important.
There's been a lot of money put into the clinical effectiveness to determine what's effective and what isn't, so that physicians have more information to go on as far as what's appropriate care.
Joan asked a good question. Won't outcome-driven rewards provide a disincentive for taking on very sick patients?
No.
There needs to be risk adjustment included so that those providers who take on the sickest patients get the greatest rewards.
But there are challenges there, and it's a very good question he asked. We do have to do that, but I'll tell you, I was speaking to a colleague the other day, and we were talking about what's called bundled payments, which may be part of some of the reimbursement system in some places, which means the patient comes in for a problem, a total amount of resources allocated for the whole care of that patient. But will that mean that the primary care physician doesn't consult the infectious disease specialist? That's a concern I have. I mean, I think these things have to be worked out, and that's why a very well integrated system, I think like Hawaii Pacific Health is working on, obviously what Kaiser's been doing, is important, because we need to not disenfranchise our specialists. They in many cases are our best minds in healthcare. So these are the finer points that have to be navigated as we implement the Affordable Care Act. It's not all about population health. Some of it will be about the nitty-gritty in the hospital, making sure people still get, in America, you still get top-notch specialty care. It's just we have had our health economics out of kilter, and that's what the Affordable Care Act was meant to get back on track.
Well, I can tell you at Hawaii Pacific Health, we have absolutely no intention to be avoiding those sick and complicated patients, because the reimbursement mechanisms that we are working on need to be appropriate for the population of patients that you're taking care of. So if you have a patient that has multiple problems, you need to have a pool of funds to be able to take out the best care of those patients. It's different than someone who's healthy and really doesn't need a whole lot of attention.
In your organization, what do you see as the biggest single change that's going to take place in the next 2 years?
The way we get paid and the focus on quality outcomes.
And that's going to simply because it's going to be demanded by the act.
We're demanding it. We want that kind of reimbursement so that we can put our resources into the right place and put them into prevention. And for instance, a patient who has multiple complications, say they have diabetes and heart disease and they've got I don't know, the mental health problems, that you have the resources that you can put in to keep that patient out of trouble, and that needs to be intensive, multiple people involved in the care of that patient, and there's good models of where that's been effective in reducing costs and improving the outcomes for these individuals.
Biggest change in the next two years for your organization?
It's really going to be the exchanges and the individual mandate, with the people who are currently uninsured now becoming insured, and we are doing a number of things such as building a new clinic in Kona and expanding our Ko'olau clinic so that we can meet the needs of our community as we get more of the uninsured as insured patients.
You get 15 seconds, he gets 10. What's the biggest change next?
The way we deliver health care, we are going to be patient-centered. We are going to put more of an emphasis on primary care and the teamwork model, and we are going to be looking at results.
And I say we have to not forget that the patients and physicians are the center of the healthcare system, and I think we'll be able to achieve that with the Affordable Care Act.
Listen, we got a lot of calls. A lot of people don't quite understand, as like me, and I think they appreciated what you all had to say, and we'll undoubtedly do this again in a few weeks. I'm not sure. Thank you very much for coming. Next week, we'll be taking a week off from Insights to bring you special pledge programming, so we want you to get your checkbooks out and get ready for that week. In 2 weeks, we'll talk biotech. That's the development of genetically modified crops, such as papayas and corn. GMOs have generated controversy both here and on the mainland, so we'll talk with people working in the industry and some of their critics. We'll explore the current labeling debate as well as the public health and environmental issues. That's next time on Insights on PBS Hawaii. I'm Dan Boylan. Ahui ho.